All right, good afternoon, everyone, and good morning for some of you joining from the West Coast. Thank you for attending today's webinar, Identifying and Managing Hepatitis B at the Primary Care Level During COVID-19, hosted by the National Nurse-Led Care Consortium and Hepatitis B Foundation. So we are approaching the end of Hepatitis Awareness Month, so we wanted to cover important information addressing hepatitis B care during the COVID-19 emergency response in Philadelphia. I'm Christine Simon, Public Health Project Manager with NNCC, and I'll be moderating the webinar today. So for those who are new to the National Nurse-Led Care Consortium and our mission, I just want to provide a quick background. NNCC provides direct nurse-led services, and our training and technical assistance is rooted in the principles of nurse-led care. Although we have nursing in our name, our trainings are appropriate for a variety of clinical staff. Clinical staff roles and principles of nurse-led care can assist all providers in practice. So before we get started with the content of today's presentation, just a few Zoom webinar items and reminders. Feel free to enter questions in the Q&A box throughout the webinar. We will have time at the end to answer any questions. A Dropbox link with the slides for today's webinar can be found in the chat function of the Zoom platform. And for those interested in receiving credit for today's presentation, NNCC will be sending an email within the next day or two with instructions to complete a survey to obtain CE credits from Clinical Directors Network. We're excited to partner with the Hepatitis B Foundation today, and I want to introduce our speakers very quickly. So we have Catherine Freeland. She received her Master's of Public Health at East Tennessee State University with a concentration in community and behavioral health. She spent a year working in Nairobi, Kenya as a communication and programming chair for the Organization of African Instituted Churches. In this position, Catherine was working to empower, educate, and learn from grassroots community leaders through a Train the Trainer program. She's interested in reducing health disparities through sustainable projects and collaboration at the community level. Catherine is currently enrolled in the PhD program in behavioral health science at Thomas Jefferson University College of Population Health in Philadelphia. She's also the public health program director at the Hepatitis B Foundation, where she works on public health research and outreach activities throughout Greater Philadelphia. And a little later on in our presentation, we will have Dr. Robert Gish, a fellow of the American Association for the Study of Liver Disease, the American Society of Transplantation, and the American College of Physicians. He has served on the editorial boards of American Journal of Gastroenterology, Hepatology, Journal of Hepatology, among many others. He was involved in studies that led to the genotypic classification strategies and methods now in use worldwide. Dr. Gish is currently an adjunct professor of medicine at the University of Nevada Schools of Medicine in Las Vegas and Reno. He serves as an adjunct professor at pharmacy at SCAG School of Pharmacy and Pharmaceutical Sciences at the University of California, San Diego. In addition, he is also medical director of the Hepatitis B Foundation in Doylestown, Pennsylvania. Very excited to have you both today, and now I will turn it over to Catherine.
Great, thank you so much, Christine. Can you hear me okay?
Sorry.
Okay, great. So today, next slide, please. Today we'll be talking about first, hepatitis B epidemiology. We'll go into serology and testing recommendations for primary care providers, followed by management for hepatitis B, and then a little bit about hepatitis B and COVID-19 implications, and provide an opportunity at the end for question and answers. Next slide. Our objectives for today are really to look initially at the epidemiology and virology of hepatitis B in the United States and globally, highlighting Philadelphia specifically. And we'll also summarize the natural history of hepatitis B, recommend screening for hepatitis B, and discuss facts and fictions and treatment options for hepatitis B. Next slide. In the world, there are 292 million people estimated to be living with chronic hepatitis B, and this accounts to about 887 people dying of hepatitis B related complications around the world each year. And this generally means that about every 30 seconds, someone is dying of hepatitis B related complications. In the United States, there are 2.2 million individuals living with hepatitis B, and it's estimated that about 65% of those with chronic hepatitis B infection are not aware of this infection. You can see from the map where there are hotspots indicated by the darker colors, the redder colors. And so you can see that a lot of our populations where we have high prevalence are coming from the continent of Africa, as well as much of Asia as well. Next slide, please. In Philadelphia, this table really shows what we're doing and what we've seen through our local community-based screening and education for individuals considered to be high risk for hepatitis B. This table comes from the specific outreach, and I've highlighted the populations where we have seen in Philadelphia high infection rates of hepatitis B. Particularly, these are individuals who have recently immigrated from Africa, Southeast Asia, and the Western Pacific, primarily coming from China. You can see that the Western Pacific makes up most of those infected with hepatitis B from our Philadelphia populations. Of note, about 67 individuals testing positive for hepatitis B were in care or reported having a regular healthcare provider, which highlights the need for increased testing within the primary care setting, because these individuals were actually in care but had not known of their hepatitis B status prior to this testing that we did in the community. Next slide, please. This slide really just demonstrates hepatitis B infection among immigrant populations in the US at the national level. Migration accounts for about 95% of new hepatitis B cases in the US, and individuals are mostly coming from Africa or parts of Asia. The countries where they're most commonly coming from are listed here, and this is from 2009 data. So you can see the top three were China, Vietnam, and the Philippines. And so screening for these populations in particular is essential to identify infection. Next slide, please. Hepatitis B has significant health-related disparities. Asian Americans and Pacific Islanders carry about 50% of the chronic hepatitis B burden in the United States. Between 5 to 15% infection rates have been found in African-born community-based studies in the US. There's limited information on African-born communities, but we do know that they have a high progression to liver cancer if they're positive for hepatitis B. For chronic hepatitis B and liver cancer, this is the #1 health disparity for Asian Pacific Islanders in the US, particularly among Asian and Pacific Islander men. For Vietnamese men with a chronic hepatitis B infection, it is 13 times higher liver cancer rate, and then for Korean men, it's 8 times higher, and for Chinese men, it's 6 times higher. So you can see there's significant health disparities within the Asian and Pacific Islander and African immigrant communities. Next slide, please. In Philadelphia, this is data provided by the Philadelphia Department of Public Health. We have just over 25,000 individuals with chronic hepatitis B infection. 30% of these individuals are not in care at this time, and these are just cases reported to the Philadelphia Department of Public Health. It's estimated that that number is potentially higher due to lack of testing. Areas in the city where populations from Africa, Asia, and Eastern European regions have the highest cases of hepatitis B, and you can see that through the map on the slide, which really shows you where larger proportions of hepatitis B infection is occurring in our city. Next slide, please. This is looking at acute cases as well as chronic infection. Pennsylvania has the 4th highest burden of newly reported chronic hepatitis B in the country, according to the 2016 CDC viral hepatitis report, and Philadelphia accounts for 74% of Pennsylvania's cases. The Philadelphia Department of Public Health is aware of about 1.6% of residents living with chronic hepatitis B, but it's estimated that up to 65% of people are undiagnosed for hepatitis B. And this indicates that approximately another 10,000 Philadelphia residents could be infected with hepatitis B. We are seeing acute hepatitis B cases rising in conjunction with the opioid epidemic and increased injection drug use behaviors. Next slide, please. This slide really depicts this increase in acute cases of hepatitis B among persons who use drugs, which have not been targeted for program interventions in the past. While this is changing, this is just a problem of note. So people who have a history of injection drug use should definitely be tested for hepatitis B. These are also individuals over the age of 30 who are less likely to have received vaccination during childhood routine vaccines. Next slide, please. In December of 2019, the Philadelphia Department of Public Health released a health advisory noting this increase in hepatitis B cases, acute hepatitis B cases, and it was a 175% increase in cases from 2017 to 2019, particularly among persons who use drugs and those living homeless in the city. Next slide, please. In partnership with the Health Department, the Hepatitis B Foundation, and Prevention Point Philadelphia, we also wanted in 2018 to assess what is happening in terms of all viral hepatitis across the board for individuals who are high risk and have a history of drug use. And so this study worked to understand what was going on through a questionnaire and serology study to look at hepatitis A, B, C, and Delta infection. Next slide, please. So from the study, we were able to find that about 40% of this population was susceptible to hepatitis B and had no previous immunity record at the time of testing. About 26% of this population was susceptible to both hepatitis A and B and had no vaccine history for either of those. And there were 7 current infections of hepatitis B from a population sample of at 384. And 20% had a past exposure to hepatitis B. Next slide, please. The Philadelphia Department of Public Health has a really robust perinatal hepatitis B program that does work to link hepatitis B positive pregnant mothers into care to prevent the spread of hepatitis B to her newborn. Between 2016 and 2018, there were 265 accounted for mothers who were hepatitis B positive, and about 48% of those were referred to a specialist. 52% of these women were not in care, and it's just essential that these mothers are evaluated and their newborns receive both the birth dose of hepatitis B and hepatitis B immunoglobulin within the first 12 hours of birth. PDPH does have resources, and as one is depicted here, to assist in ensuring this happens to prevent the spread of hepatitis B. Next slide, please. So this is just a slide showing adult vaccination coverage. Really, we have about 25% of individuals covered over the age of 18. And this is data from 2016. So you can see those individuals with high-risk conditions are not necessarily vaccinated as we would think they would be. And so we have a long way to go in terms of ensuring protection and coverage against hepatitis B through the vaccine. And next slide.
Good morning, everyone. Calling from San Diego, so it's morning here. I think we're at the noon hour where many of the attendees are located. But thank you for having me. That was fantastic, Catherine. I really want to emphasize in your presentation that I was so happy that you were checking your patients for Delta hepatitis. And of course, whenever we talk about hepatitis B, we need to talk about vaccination. There's been a major advance in vaccination with a 2-dose regimen called HBsAg that has a much higher response rate with one less dose. So the protective level of 2 doses and compliance with 2 doses is extremely high. I'm going to dig a little bit deeper into the hepatitis B world now, and I also want to compliment the Hepatitis B Foundation for their great work. What's been going on in Philadelphia is a fantastic leadership position, and this wonderful nursing organization. I appreciate you inviting me. Hayden's been very essential in getting this set up. Thank you. So next slide, please. There is a lot of information at my website. Disclosures included, but there's a lot of educational material, slide decks, advocacy, etc. There's only one relevant company that I work with, and that's Gilead, who's in the hepatitis B space. Thank you. Next slide. Hepatitis B disease progression. This just gives you another way of looking at the impact of this disease, with 2 people dying every minute from complications associated with hepatitis B. Liver failure and liver cancer are the leading 2. Chronic infection, you heard the correct number is 292 million from Catherine. That's the number that I think is correct. You'll see different numbers in the literature. It's from the Pillars Institute, led by Homi Razavi. And look at this small number of people diagnosed. How are we going to reach hepatitis B elimination with a very low testing rate? So if you look at the WHO document, they basically advocate that all adults be tested for hepatitis B. We're working on that in the United States. The Hepatitis B Foundation is stating that all adults should be tested, but the CDC and Preventative Health Services Task Force has not reached that yet. Let's hope they reach that conclusion in the next year or so and move forward with testing. We can't eliminate unless we test. Next slide. This is an old disease. This is a 16th century Italian mummy that had hepatitis B, but this disease actually dates back 40,000 years. There is a paper that I'll have published shortly that will be on my website. Also will be in a text and PDF format about the history of hepatitis B, dating back to East Africa and moving with the egress of Homo sapiens out of East Africa around the world. So hepatitis B has been with us for a very long time. Next slide. Look at this incredible need. The US, where we're sitting, we have a large number of individuals, 2.2 million, we think, in the US that are infected by the presence of surface antigen. Large number of people, 1 million people dying every year of the consequences of hepatitis B, despite having a vaccine available for over 30 years and effective antivirals with minimal resistance for 20 years. Next slide. A little bit more on prevalence and where the heavy locations are. The reason I brought up this slide is to reinforce what Catherine presented. We have a large number of individuals coming, not just from Asia, where we usually think about hepatitis B being high prevalence, but from Africa as well. Next slide. Vaccine does make a difference. This is just giving you the prevalence of hepatitis and where hepatitis B vaccine is taking place. We have a change in this map, a decrease in the prevalence. Some of these deep red countries are moving to orange and light yellow. China has had a huge impact, moving the prevalence from the 8 to 12% range down into 3 to 6% range, just to give you one example. Next slide. Prevalence of hepatitis B and linkage to care. So we're not just giving you numbers that we think is a baseline, but diagnosed, small, and receiving treatment even smaller. So it's pretty, I think, simple to remember. About 40% diagnosed, about 10% receiving treatment. This is not a curable disease, but hepatitis B is suppressible. And when you suppress the virus with our best 3 oral therapies, one is called Entecavir, one is called TBF, the other is TAF. Those two are similar to each other with a tenofovir base. You can suppress virus and change outcomes. You can basically prevent the development of cirrhosis. You can reverse cirrhosis. You can reverse liver failure, and you can decrease the risk of liver cancer. Next slide, please. Special populations, well, everybody is special. We think everybody should be tested, but this gives you an idea where hepatitis B is found. I'm just going to highlight on the left side, the incarcerated population ranges from 1 to 10%. Upper right-hand corner, individuals who inject drugs, and you heard from Catherine about the rising number of acute disease. And of course, that's an increase in chronic disease as well. There's a significant number who are co-infected with HIV and hepatitis C. And we still have about 1,000 babies born to mothers each year who have hepatitis B, meaning hepatitis B transmission takes place with 1,000 newborns infected with hepatitis B. The number is higher than that, of course, where transmission, but some of those babies are able to clear their hepatitis B infection. Sexual transmission also needs to be highlighted. Next slide. Disease impact and progression. So chronic hepatitis means inflammation. Chronic infection means that that individual has the disease but does not have inflammation. So inactive disease can happen early, also can be part of the mid stage of this disease. We usually tell our patients that the risk of developing cirrhosis, if they're surface antigen positive, is in the 40% range. That's cirrhosis. And then those patients with cirrhosis can move on to decompensated disease or liver cancer. Not every patient with cirrhosis progresses because we have effective therapies, and occasionally patients clear the infection on their own. Chronicity means surface antigen positive 6 months after acute infection, One thing that's been a problem with health department reporting is that often they will just say, oh, you have one surface antigen, and we're thinking that's acute disease. You have to have two to prove you have chronic disease. We disagree with that as an organization and as an individual. When a person has surface antigen and they come from a high-risk part of the world, or they're 20 years old and their mother has hepatitis B, that's not acute disease, that's chronic disease. So one S antigen positive actually indicates chronic disease in most individuals. Next slide, please. The level of virus in the blood, quantitation of hepatitis B DNA determines outcome. So the higher the DNA, the higher the liver cancer risk, the higher the cirrhosis risk. So we measure, after measuring surface antigen, we measure quantitative HBV DNA levels, and that level determines if we're going to treat alongside ALT and alongside liver imaging. Liver imaging means a baseline ultrasound in all patients. Now we have the ability to get a test called a FibroScan that can determine stiffness and also can help us determine level of fat. So DNA levels are part of the algorithm about who should be treated. What's the magic number? I like to keep it simple. A level of over 2,000 should bring about a treatment discussion. Over 2,000 elevated liver enzymes. ALT specifically is a liver enzyme, not a liver function test. ALT is a liver enzyme. Over the upper limits of normal, 25 in women, 35 in men, a stronger reason to treat. The DNA level, let's say, is 800, but elastography or an ultrasound shows advanced fibrosis. We're going to treat. Next slide, please. One other advanced test that we do is something called quantitative surface antigen. This is a test that's available through Quest, and that quantitative S antigen relates to a number of different things: infectivity, risk for liver cancer, risk of transmission, risk of progression. If someone's clearing infection on their own or clearing infection on treatment, quantitative S antigen, very, very useful. And I'd order this on every patient at baseline, and then every 1 to 2 years and follow-up. Next slide, please. Hepatitis B remains a serious disease. As you can see in this hepatitis clustered together, we have a rising number of deaths. This is global information from WHO. The rise in deaths due to hepatitis B is now dominant in the hepatitis world, viral hepatitis world, because we have a cure for hepatitis C now, and so many patients are having treatment with hepatitis C. There are hepatitis A and hepatitis E outbreaks, and Delta hepatitis, unfortunately, we don't have testing information here, but Delta hepatitis, hepatitis D, is the most serious of all of these forms of viral hepatitis, and of course is linked to hepatitis B. It lives with hepatitis B. It's the only virus in the viral hepatitis world. One virus lives with another. Because of the high mortality rate with Delta, all B patients should be tested for Delta antibody at a minimum. Next slide. This is the cost of hepatitis B. Well, you have direct costs. You have the cost of medications, you have the cost of monitoring, and then you have downstream costs. This has to do with developing cirrhosis, needing a liver transplant, managing their liver cancer. All these are very, very important issues. And comorbidities. If you have hepatitis B and fatty liver, you have a much higher risk of liver cancer and a much higher risk of progression than with fatty liver or hepatitis B alone. Next slide. This just talks about elimination. Now, I'm not going to go into all the details here because we've actually covered most of this information in the slides, but we have a problem. We are having great difficulty decreasing the transmission from mother to child to 0. We're increasing the rates. We have an increasing rate of acute hepatitis B. That's not going to meet our goals for hepatitis B elimination. And of course, we have problems with hepatitis A and C elimination as well. Now, we're reducing the rate of hepatitis C related deaths, but we're not meeting in the US WHO and international goals of targeting elimination for B and C. This is really a problem. So this is information about reaching these specific US-related goals, but these are not reaching WHO goals. Next slide. Let's talk about testing. Now, we've already talked about a lot of this, but I want to review it because I think this is a very important slide. Surface antigen, if present, indicates infection, and that's the foundation of hepatitis B testing. But every patient needs 3 tests. Every patient should get an anti-core antibody. If core antibody is present, it means exposure. Exposure to an incurable disease means persistent disease. We'll get back to that in just a moment. Surface antibody equals immunity only if surface antigen, and more importantly, core antibody, are negative. So if you have all 3 tests negative, you need to vaccinate those individuals. If a person has surface antibody alone, they're immune, don't need further vaccination unless they only received 1 out of their 2 vaccines with the HBsAg B vaccine that we talked about. And that's what we use in San Diego, where I work in a federally qualified health center called La Maestra. And this vaccine, this 2-dose vaccine, is being used nationally at many organizations and is moving to front line now that people realize the efficacy of this vaccine, the compliance, the protection, and the protection in special populations. Now, if somebody has core antibody alone, surface antibody is negative, surface antigen is negative, that person has to be considered still infected with a very low level of virus. I call it a sleeping virus in their liver, provided that their liver enzymes are normal. If somebody has core antibody alone and their enzymes are elevated, I'm going to measure that HBV DNA level that we just talked about and quantitate that and look for something called occult hepatitis B. Now, what do we do with this? Number 1, we educate the patient. Risk of reactivation. Reactivation can occur with hepatitis C treatment, with chemotherapy, with immune suppression, with organ transplantation. So you do a lot for the patient by telling them about the reactivation risk, not to frighten them, but to educate them and make sure they're aware of the need for monitoring. Secondly, we save money because we don't give these individuals vaccine boosting. This vaccine boosting in core positive patients has been going on for the last 3 decades. But we need to halt this. And I'm following not just my recommendations, but I'm following what the CDC advises too. They've realized that this test for core antibody is extremely specific, meaning the false positive rate is only 2 per 1,000. With a false positive rate that low, core antibody equals residual virus in the liver. Again, we call it a sleeping virus, provided they don't have active liver disease. And of course, surface antigen. We test for Delta, and then we go on to second-line testing. There is no such thing as natural immunity. That word, that term needs to be banished from the literature. This is an incurable disease. It's like CMV or herpes or Epstein-Barr. You're infected, you carry the virus the rest of your life. But if you've cleared surface antigen, you basically have a very normal lifespan from a hepatitis B perspective. Next slide, please. Now, when that surface antigen comes back, I immediately work through a second level of testing. I'm not going to go into depth about all of these tests, but this is very important for you to have in your pocket, in your mind, as a healthcare professional or as an advocate. E antigen and E antibody are used to determine the phase of hepatitis B. We talked about Delta, co-infection with hepatitis C and HIV. We reviewed that in at-risk individuals, but everybody who's got B should know their hepatitis C status. As you know, we have universal adult testing for hepatitis C in the US now. And of course, HIV is almost universal in adults up to, I think, an age currently of 65 or 70. All surface antigen positive patients need imaging. We talked about DNA quantification. We want to make sure those individuals are immune to hepatitis A, and if not, get the 2-dose hepatitis A vaccination. You'll see something called a GALAD score. That's a triple panel AFP, DCP, AFP, L3. Then you calculate an L3%. The GALAD score gives an immediate and out to about a 5-year risk for developing liver cancer. I do a FibroScan and something called CAM. Oh, it should be CAP. I'm sorry, that's misspelled, CAP. Controlled attenuation parameter, CAP, that measures and assesses for fat in the liver. And the hepatitis B world, we need to know patients' fatty liver status or NASH status. Next slide. Part 3, I'm going to look at the liver enzymes. AST and ALT are not liver function tests. Those are liver enzymes. Of course, I look at liver function, albumin, bilirubin, and in selected patients, I do coagulation tests called an INR. I ask them, is there a family history of liver cancer? Because that would indicate in that individual that is surface antigen positive that's with you in the clinic, or with your family, or you may be advising that they have a higher risk of liver cancer, and you may start surveillance earlier. Surveillance is regular testing. Screening is the first test. People often get those two things confused. So your first test is screening. If you're doing regular testing, the correct term is surveillance. We rarely do liver biopsy. We may do other tests of fibrosis. There's one called Fibrosure. There's a new one out called ELF from Siemens. It just became available in the US. We advise our patients not to drink alcohol. We take a thorough alcohol history and educate that alcohol, like fatty liver, can accelerate liver disease due to hepatitis B. We assess renal function, we assess bone health, and pregnancy education. And if the mother, of course, is surface antigen positive, she is pregnant, or has had children, we're going to test those children, and we're going to take appropriate protection for the baby when born with vaccine and hepatitis B immune globulin. The mother is replicating, virus has over 200,000. That individual would be on TDF, that tenofovir derivative that's been proven safe in pregnancy and can decrease transmission. And then the final work is to bring in the entire family and, of course, spouse, contact, significant others to get the triple panel. Next slide, please. This is a table that you can use, you can print out. It talks about the profile, what the significance is, and what actions need to be taken. I'm not going to read through this slide, but we've got some yellow highlights here that re-emphasize what we've discussed on our previous slide. I always like to insert this and have people use this, have it posted in your office, on your desk, handouts at screening events in the community, just as a great reminder about the different profiles. We call this Profile 1 through Profile 5. This is derived from the test that we talked about already, makes things very, very simple also. And when we talk about surface antibody and core antibody positive that we used to call natural immunity, we don't call that natural immunity anymore. We call that immune control. So if the surface antibody is positive alongside core, that individual is not immune because they still have virus in their body. They have virus in their liver. But that immune control means their risk of reactivation is very low. So no more use of natural immunity, where that term is gone. But you can see in green here, immune control. Thank you. Next slide, please. A little bit more in natural history. This is what I call the 5-phase model. And there's a lot of information on this slide. I'd like you also to keep this in your pocket. The testing process is very important. So you get baseline information on everybody. And if someone's surface antigen positive, they're going to come back for testing every 6 months. And you're going to determine if they move through this natural history, where they are in this natural history, and if they're moving out to immune control. Are they moving to surface antigen loss or not? Every 6 months, once a year, I do quantitative S antigen. The people who are S antigen negative but core antibody positive alone, I wouldn't do repeat testing in those individuals unless they become immune suppressed or they're being treated with hepatitis C direct-acting antiviral agents. When you treat C, you can reactivate B. This has to do with a shift in the immune system and immune control. If someone's core positive and surface antibody positive, their risk for reactivation is extremely low, and I rarely would retest them unless they got something very potent that would suppress their immune system, such as Rituxan, which is used for lymphoma. Next slide, please. We mentioned liver biopsy, but this is rarely done. But when we use our non-invasive testing, we do stage patients. We use our FibroScan, we use our ultrasound, we use the AST to ALT ratio. I didn't emphasize before platelet count, but platelet count's very useful. A normal platelet count in healthy people is 250,000. If a person's got surface antigen positive and the platelet count's under 170,000, it's very likely they have F3. If it's under 100,000, it's extremely likely they have F4 or stage 4 cirrhosis. So you can look just at the platelet count in a hepatitis B patient and get a lot of information. Next slide, please. Well, you heard about this problem with IV drug use and a rising prevalence of hepatitis B. This is why we need to test all adults. People aren't effective at taking a risk history. So let's just test everybody. Let's make it simple, especially if we're going to try to get to our elimination goals and try to protect all adults. This is a chronic infection. We don't have a cure for hepatitis B like we have for hepatitis C, but we have a fantastic vaccine. We have a number of vaccines. Actually, there's 3 vaccines for hepatitis B. 2 of the manufacturers are 3-dose, and we have a new 2-dose vaccine. This can take this rate down close to 0, this prevalence and incidence. Like we've seen in a fantastic country, Taiwan has led the world in vaccine elimination of hepatitis B. Next slide, please. Significant need for hepatitis B protection. This is just new cases of hepatitis B by age. It's affecting everybody. Why is it so low in 0 to 19? We have a very effective vaccine program in infants, and you saw Catherine present how well they're doing in Philadelphia. There's always room to improve. We're still having 1,000 babies a year develop hepatitis B, but this is a huge improvement from 5, 10, 20 years ago. Next slide, please. Foreign-born, you already heard a lot about this in the Philadelphia area. This is giving you information with Central America, Asia, Europe, Caribbean, South America, Africa being a number of foreign-born in the US by place of birth. Next slide. Well, we have 2 different patterns of hepatitis B transmission. In Asia, Africa, South Asia, it's vertical transmission. In North America and Western Europe, it's adult transmission. Now, the good news about our region is adult transmission has a much lower chronicity rate, a much higher clearance rate of infection. So let's keep that in mind, but it's still a serious disease in all these individuals. Next slide, please. Institute of Medicine talked about barriers to prevention, barriers to control. What are we doing today? We have an educational knowledge seminar. We're increasing awareness. So we educate one person, that person educates another 10 people, that person educates another 10 people, and we have this amplification of information that's taking place through lectures, through great organizations such as the Hepatitis B Foundation, through ECHO programs, through CME groups like CLDF and CCO. You saw one of the slides from Clinical Care Options earlier. There's a very effective way, and fortunately, we have pharmaceutical companies that reinvest their money back into education, which is really a critical part of this too, because we have treatment for hepatitis B. But people need to know how to use those medications and very rare side effects, but need to monitor for adverse events. Next slide, please. Projected outcomes, screening needs to be widely used by all adults. The primary care setting is the best place to start this process. Community events, advocacy groups, policies. Let us keep our fingers crossed, hope and pray that the CDC and Preventative Health Services Task Force will advocate and make it a policy. And then we'll have milestones and metrics to test all adults to bring about this effective elimination program. And of course, linkage to vaccine. Next slide, please. Prompt identification. We have a lot of things that we can do for those individuals. We've talked about the benefits of treatment, but remember, By treating people and decreasing virus or clearing virus, we decrease their infectivity. And there's a major number of education programs that can take place as well. Next slide, please. So candidates for screening, let me just take you to the second line, all adults. We're also going to check children who are born to mothers with hepatitis B. And of course, if you have an adolescent in a high-risk setting, we're going to check and make sure that they've been vaccinated by taking a good history. You may want to check for immunity in those individuals as well. But boosting right now is only advocated by the CDC in individuals who are panel negative, you're not sure of their vaccine history, and they're having either high-risk behavior, IV drug use, or high-risk sex, or they're HIV infected. Those are individuals where checking and boosting. But if you're core antibody positive, we don't recommend boosting. There's no data in the world that you're clinically benefiting those patients. Next slide, please. What about testing in a person with a history of vaccination? Well, someone says, I had the vaccine, but I don't know how many doses I got. Well, what we do in those individuals is you can do one of two things. You can just give them a single dose of HBsAg B, that'll be their second dose, or you can check antibody levels. If antibody's undetectable, but they think they've had vaccine, and those individuals, you also would give them a second dose of HBsAg B. Or if you don't have HBsAg B available, then you'd give them 2 doses of one of the other vaccine alternatives, which are very, very safe. I just want to highlight there are very rare complications of hepatitis B vaccine. The benefit is 100 to 1,000 times better than the risk, and we know that this is the best vaccine preventable cancer in the world. Liver cancer is vaccine preventable. Can't really say that about any other vaccine that we have available for preventing cancer. Next slide, please. We talked about tests, we talked about core antibody. This just reviews this information in a different format. Next slide, please. Guidance about treatment. We talked about ALT and HBV DNA. This slide and the next slide covers that for e antigen positive patients, wild type infection. Next slide. E antigen negative patients. If they're e antigen negative and positive DNA, elevated DNA, those individuals have a mutation called a core or pre-core mutation, or both. They're at even higher risk of progression, because it's very rare that those individuals would end up having immune clearance of surface antigen. Next slide, please. Simplified treatment, DNA over 2,000, elevated ALT, evidence of fibrosis. Sometimes we treat people, let's say their ALT is 25 in a woman, DNA is 800, they're in their 50s or 60s, more likely to treat those individuals. They have elevated liver cancer risk biomarkers that we talked about. We deem them at high risk for liver cancer, such as with fatty liver and hepatitis B, or alcoholic liver disease, alcohol use disorder. When someone has liver cancer, you're going to treat the hepatitis B at any level, because they're going to be at risk for reactivation with the treatment of their liver cancer. Any patient with cirrhosis in any DNA level, you're going to treat. Next slide, please. Guidance on monitoring and testing is a very important slide. We've covered frequency, which is 6 months as the rule for tests. Liver cancer surveillance, highlighted here, an ultrasound, and the triple liver cancer biomarker panel every 6 months in those individuals at risk. So who's at risk? Well, in men who are African-American or born in Africa, I'm going to start at age 20, although the guidelines start a little bit older than that. Men over 40, women over 50 at any level of replication. Elevated liver cancer biomarkers, I'll start liver cancer surveillance. So I have a low threshold to start HCC surveillance. Every 6 months, ultrasound and biomarker panel. Next slide, please. A little bit more on surveillance. Again, take that family history of liver cancer. And then we talk about African-American men. There is some data that they're at higher risk for liver cancer. If someone's co-infected with Delta, you're going to start liver cancer surveillance at any age. Next slide, please. So we have efficacy with our current therapies, we talked about Entecavir, TDF, and TAF, potent viral suppression, can reverse fibrosis and cirrhosis, prevent progression to liver failure and liver cancer, but they have a low rate of S antigen loss, and that's why we're coming up with many new therapies. There's about 30 medications in development by our pharmaceutical partners to help cure, functional cure, not a sterilizing cure, but functional cure, and reach that ideal world of immune control. Surface antigen negative, core antibody positive, surface antibody positive. That is not natural immunity, that's now called immune control. Next slide, please. Entecavir, very efficacious. This is in terms of DNA suppression in blue. 5 years, 94% of individuals in this study cleared DNA from their blood. And it's that DNA that's linked to cirrhosis and liver cancer. Low or clear DNA, much lower risk of liver cancer or cirrhosis. Next slide, please. Tenofovir, TDF, we have 8-year data. And now we have 4-year data on an advanced form of tenofovir called TAF, tenofovir alafenamide. Tenofovir alafenamide TAF is comparable to TDF, but safer with less risk of bone and kidney problems. So TAF is really a preferred treatment, especially in our risk populations. May have diabetes, older age, renal insufficiency, bone disease, at risk for bone disease. Next slide, please. This is chronic hepatitis B with recommendations from EASL about monitoring bone, making sure you've identified kidney issues. Resistance is a rare problem these days, but if someone has resistance to a previous drug, such as lamivudine, which used to be used extensively, in my opinion, shouldn't be used anywhere, it's best to put them on TDF or TAF. Next slide, please. Vaccination, 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 vaccination. Keep vaccination on your list. This is a vaccine preventable disease. We really want to give that birth dose of hepatitis B vaccine within 2 hours of birth. That was highlighted in a recent paper in New England Journal of Medicine, that vaccine within 2 hours might even decrease the need to treat the mother with TDF during the last trimester. Wouldn't that be amazing if we could get that 2-hour birth dose and not need to treat the mother for 3 months to lower the viral load? More to come on that. Next slide, please. Vaccination at the time of testing. Some people do incident to vaccination, but there's a little bit of a problem with this. It costs money. And then if people don't come back, they think they've been vaccinated and they're protected, but they may be surface antigen positive. So I would only do this in a very controlled setting where you want to be efficient and you have the resources. But my advice is you do your testing and then you have an immediate callback. If someone's negative for the triple panel test for hepatitis B, you bring them back for their 2-dose HBsAg B vaccine program. Next slide, please. All right, let's get to a wrap. I call this the 6 pillars, 6 simple messages. Test all adults. Well, there's an at-risk population that you're going to see in the CDC, but we're going to simplify. Test all adults. Core antibody. Let's get rid of this natural immunity term. This is a presence of this test, means exposure, means they need to be educated about reactivation. They do not need vaccine boosting because there's no benefit, maybe cosmetic, but it's not going to benefit them clinically. Vaccinate all adults who are triple panel negative. The new ALT has upper limits of healthy, 25 in women, 35 in men. Look at the platelet count, do an APRI or FIB4, those are free. They're online tests that combine enzymes and platelet count. Get a quantitative DNA level, check for delta, stage for cirrhosis. Treat with our therapies until S antigen loss plus 12 months consolidation. Treatment changes outcomes. Next slide, please. There are a lot of resources available. We have the hepatitis B website at University of Washington. We have the CDC. Of course, we have the Hepatitis B Foundation. They have incredible data on their website. Resources. There's an email site. There's a phone number. And of course, we have our Philadelphia program. Catherine, fantastic work with your team. I think we're at a wrap now, and just take questions. I'll back to the moderator.
Great, thank you so much, Dr. Gish.
Of course, these slides are shareable and can be emailed out or through a Hep B Foundation website, through my website. Maybe the moderator can clarify. Thank you.
Yes, we will send out the slides after today's presentation, so you'll have access to those. And we'll also send out a recording. So we are recording this today, and that will go out in the email as well. So we do have a couple minutes for questions if anyone wants to put them in the chat box or the Q&A box on Zoom. And while we're waiting for some of those questions, I have a question for either Catherine or Dr. Gish. When do you think the CDC or the U.S. Preventative Services Task Force might update the Hep B recommendations to possibly adults, all adults?
So there's actually a call out for comment right now to update those guidelines. So we are asking and requesting for primary care providers like the ones maybe on the line, nurses, healthcare professionals.
Any questions? Oh, hang on 1 second. My sound just went off. Sorry, Catherine.
It's okay, no worries. Yeah, so there's a call out right now for comment on the USPSTF guidelines for hepatitis B screening. And so we are putting out comment from the Hepatitis B Foundation and through our local and national coalitions. So if you do have comment, you can reach out to me or Christine on the emails provided on the sheet, and we would love to have your feedback on your suggestions and thoughts. We're definitely pushing for universal screening for hepatitis B. I don't know if that will be accepted, but that's our goal, ideally. I'm sure Dr. Gish may have something to add to that.
Well, one of the items in our wonderful intellectual U.S. environment is we have this Preventative Health Services Task Force that does this deep analytical dive, and they require very high levels of evidence that something is going to, quote, work. Well, sometimes we don't have that much evidence. We can't wait 20 years to get that evidence and have tens of thousands of people die gathering the evidence. We know that this is a leading cause of death worldwide, a leading cause of cancer. We know that risk-based testing is terrible, ineffective, it doesn't work. So if something's not working and you're going for elimination, and we have vaccine, and we have treatment, and we're changing outcomes, to me, I'm very simplistic, just test everybody. Make it simple, and that gets a linkage to care, the proper care, to our adult population. The children, fortunately, to our infant vaccine program from HRSA and many other organizations has been wonderfully effective.
Great, thank you. A couple other questions coming in. First question, how do I order Hep testing and have insurance and medical or Medicaid cover it?
All insurance companies cover this triple hepatitis B panel that we talked about. Now, of course, our position has been moving to make sure you know your hepatitis A and C status. So we have something at the Hepatitis B Foundation called Know Your ABCs. But insurance companies universally cover this. I haven't had any pushback from Medicare, Medicaid, Medi-Cal on testing. And it has to do with policies that are at the state, Department of Health, and US level. Remember, when you talk about hepatitis testing, you're talking about hepatitis B triple panel, hepatitis C antibody, and hepatitis A antibody, but do not order IgM testing unless somebody is in front of you and it looks like they have acute disease. We have fixed Quest and LabCorp, fortunately. It used to be the pop-up menu automatically checked for IgM core, which is a nearly worthless test, except in very special settings. And it doesn't really give you information about exposure. So surface antigen, core, total antibody, surface antibody, and you might even get a titer of the surface antibody. And that's the simple rule. Hopefully that answers the question.
And another maybe similar question, more specific for someone who 62-year-old and they've had a Hep B vaccine in 1992 and found to be immune per titer, how long does the immunity last?
Well, we have data that goes out to 20 years. We actually think it's lifelong. There are only special settings, as I think I mentioned before, where you would consider boosting. Let's say that person came in, they said they had vaccine, the primary care provider ordered an antibody test. The antibody was negative. If you're in a low-risk setting, you're just going to say you're protected. There's these memory B cells and memory T cells that allow protection long-term, even though the antibody titer may not be detectable. But if they're in a setting of, let's say they're a surgeon and they're doing vascular surgery and they're involved with very bloody procedures, I might give them a 1 dose of HBsAg B. If they're having high-risk sex and they're antibody negative and core antibody negative, I would also consider maybe a one-time booster in those individuals, but only in super high-risk settings. Otherwise, lifelong protection is the rule.
Great, thank you. I think we just have time for one more last question, and for either, have you seen any challenges that COVID-19 has presented for patients in Hep B treatment?
Yes, you probably heard the news. I think it came out yesterday that there's a large number of people that are not getting their routine health care. So that means they may not be getting hepatitis B testing, they may not be getting liver cancer surveillance, they may not be refilling their medication, they may have trouble getting access to their medication because of inadequate access to providers. So that's really the COVID-19 environment. Now, if people have chronic liver disease of some type, there's a hint that they might be at higher risk of a COVID infection, the SARS-CoV infection, and COVID meaning the disease, that may affect their liver enzymes and rarely liver function. So you might check a bilirubin. So if somebody has hepatitis B, fatty liver, other diseases, I'm going to be monitoring their liver enzymes and liver function more frequently.
Great, thank you. So that just about brings us to time, and any other questions that come up, here's my email, and I'm happy to get in touch with Catherine or Dr. Gish to get the answers for you. So just a few announcements before we wrap up. We wanted to share a new resource from NNCC, our hepatitis C virus cost calculator. This evaluates the financial feasibility for health centers to expand their hepatitis C programming with the updated CDC guidelines, so testing all adults regardless of risk factors. So please visit our website to learn more about the new resource. And again, my contact information is on the website. So if you have any questions, please feel free to reach out to me. And finally, we have a virtual conference with NNCC and the National Forum of State Nursing Workforce Centers. So registration is still open. And again, you can find more information on our website. And I just want to thank everyone again for joining us, and thank you for your questions. And a big thank you to both of our speakers.